and this is the Compliance Guy Live. This is our first Monday roundtable of 2026. I am incredibly excited, as I am pretty certain all of you are. So we have expanded the Monday roundtable. We've had a couple of our old faithfuls, if you will, kind of take a pause, take a hiatus. We love Christine Hall. We love Paul Spencer. I am so grateful for the last 2 years of their expertise and their time and willingness to share their skills and their knowledge with everybody on this podcast. But now we get to reintroduce, of course, my very good friend Terry Fletcher, my very good friend Stephanie Allard, my very good friend Scott Kraft. These are the cast of characters that you all have become accustomed to, and now we get to add 3 more to this all-star cast, which I'm extremely excited to have with us today. Jordan Johnson, he is the co-founder of Bridge Oncology. Joe Rivet, who is an attorney with Rivet Law out of Michigan. And we have David Duhaime, who is part of Doctors Management's team in the strategic litigation services area. David brings a tremendous amount of background and wealth of information from the inside for all of us now, as he was the head of a former UPIC, or the former head of a UPIC. And I always worry when I say the term former because it sounds so nefarious. So I try to be careful with how I use that term. But David has a lot of experience with the Office of Inspector General of the Department of Justice and the Centers for Medicare and Medicaid Services. So with that said, I want to welcome each and every one of you to the 2026 Roundtable. It is such an honor and privilege to have you guys and ladies with me. And I'm looking forward, just as everybody else is out there, to having a fantastic first show. All right. So with that said, I want to start with talking about prior authorizations. And Joe, I'm going to come to you first because I know you have a background working at a very large payer where you used to fight on behalf of the insurance companies with respect to prior authorizations and medical necessity and some of the things that we're going to be talking about today. And now you are on the defense side, and you are helping providers to be able to navigate this area of high complexity. There's a lot going on in the world, but let me start with you. And if you could kind of lay a little bit of a foundation, if you will, for our listeners on really what's going on in the world of prior authorizations.
Right. So prior authorizations, it's essentially really kind of the gatekeeper, if you will, to some extent, to help control costs and unnecessary medical spend. But there's been this constant tug of war with prior authorization. And I would say more so in the last few years of going, which some would say too far, where perhaps it's overly regulated. But from you have to look at it from really a public policy perspective of how controlling healthcare costs. And sometimes those really expensive procedures are sometimes unnecessary. And you could go with a lower cost procedure diagnostic study. That's not always the case. The problem is it's really created a barrier between access to care in a timely fashion, which could be really critical for the health and welfare of a beneficiary. So there are a lot of the states, I would say nearly all the states, have some form of prior authorization law on the books. And there are also a few in Washington that have been pending for quite some time. They're sitting in committee to really, I'll say, overhaul, but take, I think, another look at prior authorizations to where it's becoming less of a burden between practicing medicine and delivering care for the patient. Then you have the whole claims perspective. Just because you have a prior authorization doesn't mean that that claim has been adjudicated correctly. There are a lot of issues that come around with prior authorization. And in some instances, you don't need a prior authorization at all, despite what the healthcare company tells you. So there's a lot that happens in this space. And I would say that those practices that are more specialty focused, that really rely heavily on prior authorizations, are probably very familiar with the headaches that come with this topic.
That a little bit. I think you were spot on. So I come from the radiation oncology and the medical oncology background, and prior auth is 90, probably 95+% of what we deal with. First round denials for things like proton therapy are almost automatic for everything that we do, and it has become a barrier. But also, we saw this year we got a new set of codes where it's starting to simplify, and the big question comes up, Joe. I think you're spot on. Is how do we, if we have the data and we show exactly for this patient, this diagnosis, this is how we treat it, because in radiation oncology, we don't treat patients that differently. It's pretty standard, pretty regimented. Why are we still battling these hurdles? And the amount of money that we're spending and the physicians are spending on staff just to navigate the process, whether it be a portal, the payer, a utilization management company, has gotten to be way past burdensome. And now with these new codes, we just went live January 1st, 2026 this year with all the new radiation oncology codes, that we're getting calls from the payers on exactly that. How should we interpret this? Should we approve this or should we deny it? So we get those codes. So they're struggling with it too. And so just as much as a burden as it is for us, it's a burden for them, because we have utilization management companies that are hiring clinical people, 30, 40, 50 people, just to filter all of this. So you bring up a great point, especially with the higher specialty services.
Well, look, Congress, and we started talking about this a little bit prior to the start of the program. The Congress, the 119th Congress, is starting to take a look at this, and there are 4 bills that I am aware of that have been sitting in the House of Representatives dating back to 2025. And I think it's really important because, one of the bills that is out there ultimately looks to remove the requirement of a prior authorization, especially when it comes to the Medicare Part C. And before I address some of these, would you all agree with me? And I got to be very careful how I say this these days. Would you all agree with me that Medicare Part C, those people that are selling these plans to our seniors, they're doing them a grave injustice, because Medicare Part C is nothing like traditional Medicare Part B. Medicare Part C requires gatekeepers, such as the primary care physicians, who are making determinations on basically the rationing of care, whether or not somebody's going to be sent for this laboratory test, this diagnostic test, whether or not they're going to get this referral to a specialist. And I remember prior to my mother, her dementia, unfortunately getting to the point where she could no longer care for herself or take care of herself, she used to call me all the time to say, Sean, Medicare Part B is so expensive. Medicare Part C, JJ Walker from Good Times, he's never going to lie to me. Joe Namath, he was the GOAT back in the 70s for the New York Jets as the quarterback. His beautiful smile, he's telling me the truth, right? I'm going to get silver sneakers, and I'm going to get free food, and I'm going to get free transportation, and I'm going to get money in my account so that I can get extra food each month. I mean, come on, really? And I bring this up. Yeah, go ahead, Terry, because I bring this up because that's the biggest area from a federal payer perspective where prior authorizations live right now. Go ahead, please.
Well, I think that there's a couple things to unpack there and everything that was said. First of all, the bills that are sitting there waiting to be looked at, I have a feeling they're going to sit there for a while, because they've really diverted that to Bobby Kennedy's responsibility with HHS as he sat down with many payers. And unfortunately, he said, do you promise to do this? So he's taking it on their honor and basically making it a volunteer thing to, to lessen the burden of prior authorization. So there's that. But then it's ironic, then Medicare traditional and also with ASC, they now have started the WISER program, the pilot program for certain services under the Part B services for prior auth, and then looking also at ASC, which I know why they're doing that, because so many providers want that facility part, which may or may not should have. And so I know why they're doing that. But to your point, as far as the Medicare Advantage, one thing with health insurance that's kind of different from other insurances is that, for car insurance, for example, you're paying to not use it. You don't want to get in an accident, but health insurance, you're going to use it, or most people will use it. They even encourage it for well checks. So it's you have to have healthy people for it to actually, work for other people. Well, the Medicare Advantage, which for our listeners, if you don't know what Part C is, that is Medicare Advantage. When you're dealing with Medicare Advantage, it's really for the healthy person. My husband has it and loves it. He gets a free gym membership. He's so happy. He has, I know David's laughing, but you know what I'm talking about. He can go any gym and it covers it. He gets this a little amount to go to any pharmacy every month and buy whatever he wants. They give him, $50 a month. I'm like, what do you need? He goes, I don't know. Do we need sunscreen? Do we need Tums? Things like that. So they give him these credits. And then he also gets a fun little check if he doesn't go to the doctor for anything other than a well check. He gets a little rebate and he's excited about that. And it's just funny because it is for the healthy or very, small percentage that maybe have a blood pressure med or something, that a chronic condition that's very manageable. And it's very, like your mom said, Sean, it's very inexpensive compared to the premiums for the other. And so I know a lot of retirees that are just looking for an option that is, less money because of the premium. And again, the out-of-pocket share of cost is a lot less too, because it's just a copay. So I agree with you that they're, every commercial tries to sell you something and then, they don't tell you the reality of it. I mean, just listen to pharmaceutical companies. And then at the end, you hear all the side effects. And I'm sure we all sit on the couch watching these shows and go, wow, so I can save my heart condition, but I'm going to die in other ways. You just look at some of those side effects and think, okay, well, I don't want that, but does it worth saving this? So I think when you look at Part C or the Medicare Advantage programs and prior authorization and crossing it over, I think they need to do a better job at HHS and CMS, because right now and HHS obviously is covering all the healthcare with the prior authorization, and Congress basically shifting it to under HHS umbrella. And I know Scott and I have chatted about this before. It's really tough because on one hand, they're saying that it's too burdensome, it's regulatory, it's all this, and it is. And then on the other hand, like Joe was mentioning, that there are things that we have to have safeguards to make sure it's not overutilized and that is, pre-authorized, if you will. But then we get that disclaimer saying, well, it's pre-authorized, but that doesn't guarantee payment. So it's basically just putting it in their system to see if somebody might recognize it when it comes through as a claim. That's really what it is. So I'll send it over.
No, those are great. Those are all fantastic and excellent points. So real quick, I just want to give you an idea, because I said that there's 4 bills sitting in the House, right? And I think it was Terry or somebody said, oh, they're probably going to be sitting there for a while. So just to give you an idea, the one bill, which I think is probably one of the main bills, is HR 2433, which is the Reducing Medically Unnecessary Delays in Care Act of 2025. Do you know when that bill was introduced in the House of Representatives? March of 2025. And it is still sitting there. It has not come to the floor for a vote. We have HR, House Resolution 3514, Improving Seniors' Timely Access to Care Act of 2025. And this aims to reform the prior authorization process in Medicare Advantage, like what we were just talking about, following up on efforts from the 118th Congress. Well, does anybody know what the 118th Congress did? I don't. I mean, I'm still kind of scratching my head wondering what they got done. My favorite one of them all, though, is HR 639. And this is referred to as Doctor Knows Best Act of 2025. And this one's interesting because this one aims to prohibit or significantly limit the use of prior authorizations and step therapy in health plans introduced earlier in 2025. David, I want to come to you real quick because of your background and your experience working for the evil empire. So, so we have a situation where the legislators are trying to put forth something called the doctor knows best. But don't we have something in medicine right now called the treating physician rule? I understand they took it out of the Social Security Act and it's been gone for many years. But under Medicare, we still argue the treating physician rule. And if folks are not familiar with the treating physician rule, basically in a nutshell, what it says is this: a physician who is actively engaged in the treatment of a patient knows better, and individuals within the federal payer programs should give deference to the treating physician who is actively involved in the care of that patient. So if that's the case, why do we need more resolutions on doctor knows best when we already have the treating physician rule? Why is it that they're not honoring this at the UPICs or at the MACs or at OIG?
So to me, this is what I call reactionary. So when you see these things like prior auth and everything, you had an incident happen. A UPIC goes out, does an investigation. So now everybody, instead of looking this look potentially more isolated, it's a prolific issue. We have to look at everything now. So you get these knee-jerk reactions where people say, we need to do these things because we're getting beat up with fraud, we're getting beat up with this. And then they create these whole things, like you said, this whole thing about the Part C and the STEP and the things like that. Quite honestly, if anybody looks, and I've seen this before when we would get into cases against a provider, and this goes right down to what you're talking about with the idea the provider knows best. We'd look at it and say, hey, you didn't follow the regulations through A, B, and C. And they came back and said, you know why? Because A or C doesn't work and B doesn't make any sense. So I went to D. And if you're forcing me to go through those, all I'm going to do is push it through so that I can get to that because I'm more concerned about the patient's care rather than following the regulations. But from an investigative standpoint, it looks like somebody just completely disregarding the regulations. They're trying to defraud it because they're trying to get to here. If they spent more time actually looking at what the outcomes were and really does their policy make sense, you might actually see some changes. And I've seen this where CMS got told us by a CMS administrator had all these issues with transportation. So they made these 2 or 3 knee-jerk changes. Well, then they had all this confusion, these providers allegedly abusing things and everything else. CMS themselves went back and looked, said, do you realize of all of the 7 rules that we have, the 2 changes we made actually contradict with the last 2. So they created an issue that now puts the provider at odds because they've created the confusion. And like we've all talked about, Medicare is hard as it is. Now let's add more confusion because somebody makes a knee-jerk reaction.
It's a great point. So Stephanie, I want to come to you for a minute because you do a ton in the world of biologics infusion services, right? Especially in the rheumatology space. Prior authorizations are the difference between payment and non-payment. What, in your experience in dealing with the rheumatological practices or those in oncology, and Jordan, I'm going to come to you as well because this is, that's your landscape, oncology. But what have you been seeing, and what are some of the big missteps that you've seen on the part of practices struggling with the prior authorization process, or just completely missing steps in the prior authorization process?
So where I've seen issues and disconnects with this is when they don't know how to navigate either setting up processes internally or working with a good external company to accomplish this. So, right now there's obviously a lot of rheumatology networks all over the US, and Sean, we've worked with them closely. They have very solid revenue cycle support and teams that help. But when we look at, for example, a single private practice, they want to, let's say, use an external billing company, but then they're not fully understanding the revenue process. They bring someone in. How many times do we see people bringing someone in off the street with no experience? They don't want to pay them any money for the position. And then they wonder why things are falling apart. And that's where I've noticed it, where people aren't recognizing roles around these types of tasks that have to be completed. they devalue it all the time, but yet it's the base of the entire revenue cycle.
Jordan, so you and I got a chance to work together. Well, you introduced me to an organization that has automated the prior authorization process. And some people may be listening to this discussion and they're going, wait, you've simplified it, you've streamlined it. It's kind of like AI, and this is how I explain it. Prior authorization tools are just that. They're a tool. They still require accuracy from humans inputting the information on the front end and verifying things throughout, whether it's the middle or the back end. And one of the things that I saw in some of the prior authorization programs that have been created is that it's really not a true prior authorization process that's taking place. It's a validation of eligibility. It's verifying eligibility benefits, right? And there's a big difference between whether somebody is eligible to have services rendered versus somebody receiving a prior authorization that is for a specific service, for a specific diagnosis. And in the cases of chemotherapy administration or biologics for like Remicade or, somebody's Symphony Aria, whatever it may be, doses of specific amounts. So can you talk a little bit about, because you travel to more conferences, my friend, than anybody that I know. Every time I look at what's going on in your world, you're at a different conference. So you're really somebody who's in the know as far as I'm concerned with what's going on in the industry from a landscape perspective. So can you talk about some of these programs that exist, the ones that are coming out now, and sort of the good, the bad, and the ugly of what you're seeing?
Yeah, no, absolutely. So there's probably a good 30 programs that are out there in the space for prior authorization. And the one thing to remember is there is no automatic, you go from no auth to auth with one button or one software. Generally, what these programs do, to your point, is they look at steps in the process. They review the steps in the process, eligibility, benefits verification, then it tracks it. Do I need to go to a peer-to-peer? Was this denied? If so, what are my next steps? And it's looking and keeping data points on that process. Now, the problem is these softwares cost money. If the insurance companies would work with us and we would get some form of a gold card, could we reduce this, the need for these softwares? But right now, the software is stopping so much of the manual task and things that are missed because the timing, to Stephanie's point, is so important. A lot of the drugs that we use are $40,000, $50,000, $60,000 a dose, and so to miss an authorization could be the difference of whether or not a practice or a physician is in business or out of business. And so these softwares, really what they're trying to do is they're trying to work and navigate with these portals. So the insurance companies have a portal and you fill out the information. Well, can these softwares help and work and fill out the portal? Can they get the next step prepared? And that's really where the softwares are coming in. It's not that they, again, get the authorization 100%. It's all the steps. If they can cover 60 to 70% of the steps, that's huge.
So it's interesting. I did a phone call this morning with one of my clients in the Northeast and their management service organization that handles the billing of these services. And I never heard it put this way. And the manager of the revenue cycle department was pointing out to one of the employees of the organization that handles the prior authorization. Just one miss on a prior authorization for a biologic infusion can take us 20 infusions to make up for the loss on that one infusion. It could take us up to 20. I'm watching some of the comments that are coming in right now on LinkedIn, and I'm seeing some really great conversation. And Scott, I want to give you this last question, and then we're going to move on from here. everybody talks about artificial intelligence. Okay. AI is replacing humans. AI is, kind of, you know, it's the devil. And in certain respects, AI is very concerning. It's highly problematic. Joe, I may actually come back to you to give the last word on this from a potential legal perspective. But Scott, you and I work together every single day. We are auditing medical records. We're engaging with clients that have integrated artificial intelligence. What are you seeing and what are you hearing from your clients, both in the small physician group practices and some who I know you work with some of the largest integrated delivery health systems? So really, where are you seeing AI playing a role with prior authorizations at this point?
So I think AI, I think of AI as like a nascent like tool to help direct me or to help like start me on things. And one of the challenges that I'm seeing with AI from both sides to an extent is an over reliance on it to produce what we think is a tangible, defendable result. And, I say both sides because I think much as I read things that come off the provider side where I'm looking at it and I'm saying to myself, like, this would have benefited from another set of eyes, like before mine. You're taking an inefficient process and in your zeal to make it more efficient, you're just you're putting potential roadblocks in it. You're putting potential errors and slowdowns in it, and that may change as the technology improves. Like, if you ask me about prior authorization and what I hear from clients, setting aside AI, right? It's the inherent like inefficiency and subjectiveness of it that drives people crazy, and it, in some ways, like maroons like the credibility of the entire process when like if I'm looking to make like the world's greatest like hamburger, I don't go talk to like a pizza chef. And I think sometimes with your prior authorization decisions, right, you're like the specialist is not at all qualified to necessarily render a decision, or certainly not at that advanced level. And I think when you introduce AI into that formula, in theory, not reality, the way it seems to work now, but in theory, like peer-to-peer reviews should be reserved for like unique cases where an advanced dialogue between two highly seasoned experts related to the specifics of that case should be what that's about, right? And so when you're trying to use AI, to me, that's a case where you probably shouldn't use AI because you want the clinician's individual perspective of what's going on with the patient. But if this is like a rheumatologist and gets ready to do the peer-to-peer and it's like, he or she's talking to like an OB, well, it kind of mucks up that process a little bit. And that's before you get into wasted staff time and all of the other things that we hear about prior authorization. Like, I know I went a little bit off topic with the AI,
No,
but
but
I think
you
there's
raised
an
a great
important
point.
there's an important point to make there about why people dislike this process so much. And to me, like in theory, maybe this, I just think differently, but in theory, like we have thousands and thousands of patients that go through these processes. And while the practice of medicine is inherently subjective, we should have enough milestone data by now to simplify this process and really focus on those cases that are in the margins or a little bit more unique, but we don't, right? And people just feel like they're constantly at the start line again. And frankly, that's what makes people turn to AI. It's like, I'm wasting a lot of time on this stuff. How do
Yeah, I'm with you, Scott. Joe, let me come to you if I can. With
make it
respect,
easier? And it at least right now.
I think
Yeah.
Scott was frozen.
it's all right. With respect, so Joe, hey, I told you we do these things live. This is not scripted. So you want something scripted, go somewhere else. This is live. All right. So listen, Joe, let me ask you this final question about this, right? Because AI is such a fascinating topic, right? And I think it's going to be for the foreseeable future. We have seen in my estimation, an over reliance on AI. We're seeing AI now being deployed at the insurance companies to audit medical records. We're seeing AI, to Scott's point, where a peer review may take place and they're utilizing some type of AI to either agree or disagree with a subspecialist on the plan of care for a patient. Just wrapping this section up, what do you, from an attorney perspective, focused on healthcare, what do you see as the potential risks of the over reliance by practices on artificial intelligence for the things that we're talking about, especially like prior authorizations, peer reviews, things of that nature?
Yeah, so I would say there's going to be open AI and closed AI. I think the huge risk is going to be PHI and PII. So even if you're using a vendor, it doesn't mean the staff are not going outside into an open AI environment and putting in patient information into that's not encrypted, it's not secure. I think that's probably one of the biggest risks that I see. I think from a regulatory standpoint, we're seeing really some cross currents between state law and federal government. So this administration, President Trump signed an executive order that really kind of squares off or tees off, essentially. We're going to have national policy, not 50 different state policies around AI, although we do have state laws on the books today. But I don't know, I think those are probably the two biggest areas, because the risk is how we're using this patient information in an AI environment. Is it safe? And then two, are we complying with both state and federal law? And that seems to start to change, I think, pretty quickly. So that's just my assessment on that.
Yeah, I think it's safe to say we're gonna hear a lot more about AI. I think we're gonna see more investigations.
Mm-hmm.
I think we're gonna see more enforcement by OCR, to your point, Joe, with respect to the use of AI in non-encrypted situations where protected health information is being put into these systems, and it potentially leading to breaches of privacy.
Yes.
So, and it's really important, again, to keep in mind that OCR, as of February, right now, took over all enforcement for HIPAA violations. So that is a huge, huge thing. So Terry, I'm going to give you the last word on this, and now I'm going to give you the first word on our next topic. Go ahead.
Well, it's just some funny anecdote on the AI thing. So I've gotten a couple of clients that were using AI to do their audits and coding, AI companies. So they were getting these really cheap audits done for these really big, 150 physician practices. And they said, yeah, we've had to do some self-reporting because the AI either hallucinated or, obviously didn't audit correctly and told us we could do things we didn't, and things like that. And I'm like, okay. So I said, let me look at some of that now that we're taking it over. And I did. And I was like, oh boy, this is a problem. So right there, I knew that there was an issue. So then now it moved to me. Then I got two payers that came to me and said, so could you take a look at some of our AI for us? And I'm like, what do you want me to look at? And they said, well, we use it to do our prior authorizations and to also review records. And we have found that maybe it's not quite as accurate as we thought. And I was like, oh my gosh. So I looked at some of their records and it was worse than what I saw in the physician's office. And I was like,
that's frightening.
Wow, just the hallucination. I said, yeah, do you see the problem here? Here's what's really bad. And I'll end it on this and go move on. But they had the scripted version of what the AI was picking up. And Sean, you and I mentioned this on one of our #Terry Tuesdays. The AI and also the AI scribe was being turned on when the patient was roomed, not when the doctor came in. So the transcription was about all these private conversations. Look at Scott.
Oh.
Was about these private conversations. I was listening about. I was reading about things their kids did. People having conversations with a spouse in the room, talking about what they're making for dinner, talking about. One was what drugs they probably should stop taking, but don't let the doctor know, things like that. And I was just like, my head was exploding reading this. And I'm talking to this payer. And I just said, okay, so here's where you have a problem, and here's where that doctor has
Yeah.
a problem. They're like, oh man, we knew there was something going on there, and it was just it's just there's no safeguards, there's no guardrails to. And to Joe's point, thank God they're at least trying, with executive order until they can get it through Congress, which is as slow as molasses, as we know, to at least try to figure out some kind of streamlined regulation to protect this stuff. But I'm telling you, there are some huge holes in it, and the more I see in it, the more I never thought I'd say this, but I'm like, paper charts weren't so bad.
No,
So
they really weren't.
I know.
But-
I'm just saying.
But let's talk about going off the road. Let's talk about guardrails, and let's kind of
Yeah.
move into our next topic, because
Okay.
I expect this one's going to be a very interesting discussion. And I'm actually kind of excited about this one. I want to talk about what's going on with the telehealth, because there is a lot to unpack here. And I think there are some different perspectives. And what I want to say out of the gate is, listen, you as the end user, you as the audience, listening to the respected experts that are here on this panel, you need to also understand it is up to you to do your own independent research, not going to ChatGPT or another bot and relying on that to give you the accurate answer, but to do your good old fashioned research and figure out, okay, this works for me, this doesn't work for me, and it doesn't work for me, but if I do X, Y, and Z, I could potentially make this work. So Terry, I want to move into the telehealth, and for everybody that's listening right now, please don't tune out, because this is such a critical discussion. Let's talk about, Terry, your perspective on this, and then Jordan, I want to come to you. Stephanie, Joe, David, Scott, each one of you are going to get a chance to kind of chime in on this one as well. So Terry, go ahead and kick us off.
Okay, so there's two things here, and I want to make sure we clarify, because I know Jordan's thinking the same thing as we do that. So telehealth basically is virtual encounters, and being able to do that when the physician is somewhere remote, the patient somewhere else, and hopefully, I mean, they have to do that regulatorily, but the provider has to be licensed in both the state the patient's in when they're receiving care, and also the state they're in. So where are we right now? Well, right now we're in a partial shutdown. So for those of you out there, we're back to kind of what happened in October. Hopefully it'll only be a few days. They're just trying to iron out some stupid stuff that has nothing to do with healthcare, by the way. But they're in the appropriations bill. Oh my gosh, stop tagging everything and everything. But hopefully it'll just be a week. I just don't think it'll be longer than that, but you never know. The boys are not playing nice in the sandbox. Okay, and girls, I can't be sexist there. But Congress needs to just, get their act together. But that's basically what we're talking about as far as telehealth, virtual. We had, the flexibilities from COVID era that is now, we're 6 years out now. They're still extending them potentially to 2027, what you know now. But again, we're in a partial shutdown. So until they are extended, we can't give you that. But I think what Sean wanted to actually have me comment on, and this is not telehealth, is virtual supervision. Now, I know it sounds like telehealth because it's still a virtual mechanism.
See, and even I got it wrong.
I know. Well, that's why we're here for you. So virtual supervision. Okay, so I want to make sure I'm not controversial here. I just want to put it out there. What that basically means is that the definition of direct supervision, so we know there's general, there's personal, there's direct, of the physician immediately available and able to assist. Okay, so it's always been the physician has to be in the clinic and immediately available. I used to always call it within yelling distance. So if you're doing a treadmill or a stress test in one room and the provider's in clinic, again, not in surgery, not somewhere else, that you can say, oh my gosh, the patient's, having a problem, doctor come in, and then they figure it out. Well, that definition has been permanently changed and it's been updated. And I'm the first person to say I don't like it, but that's okay. That's just my personal opinion. Is that now the definition is also, not instead of, just also audio and video. So audio only doesn't work. So anybody who thinks that just a quick phone call is fine is not. But audio and video has now been added to the definition of immediately available. Now, obviously, I don't agree, because I don't think you can be immediately available, because also in the rules, there's nothing that says the doctor has to be online at the time. Well, we had problem. I mean, David, you're in a hotel room. You had a hard time getting in. So what if we have a doctor who's also having a hard time logging on? Then he or she is not immediately available, are they? And the other thing, I just had it because I tried to talk a couple of my clients out of it and said only in rare instances, is that I said, let's try a pilot program. Let's do it for 3 months, have a policy on how it's going to work, where the doctor's going to do, maybe have it set up in a conference room where the doctor is logged in. And then if you need it, that doctor is available. Well, it turned out that it didn't work out so well that way. They had one patient who was having a nuclear test, had a reaction to the nuclear. The stress portion of that test was under direct supervision. They couldn't first find the doctor. Then they finally found the doctor. Okay, I'm just going to say it. Like you said, this is podcast. Doctor was in the bathroom at his home, and his wife had to go in and hand him the phone, and then he didn't have internet in the bathroom, so it wasn't audio and video, and it just went downhill from there. And they're telling me this on a Zoom call, and I was at a loss for words. That's a new one on me. Remember when we first came out with Zoom during the pandemic, where everybody's doing cartwheels behind us, and you had dogs and kids and all that? This was kind of one of those moments where I was just like, so they said, did we meet it since the doctor was at least on the phone? I'm like, no. I go, but so the doctor was sitting down doing his business and you put him on video? They're like, no, he couldn't connect, so he's only on his phone. And I'm thinking, what if he could connect? So this is just,
You had to close Wordle.
I'm just telling you, exactly. So I know that's ridiculous, but but you can't say it couldn't happen, on a regular basis. And so my issue with it isn't that it shouldn't be used in a rare situation. I mean, I know, Jordan, you were talking through our email exchange on rural areas. Totally agree with you. There's things there that there's a reason for this. But we're not in a pandemic anymore. So why do we need to do that? We still have a shortage of physicians. So I do understand that. But when it's just routine now and being now, and there's no identifying, marking, no modifier on a claim. So how does a payer even know if a practice is using it appropriately? That's my big thing. I want a modifier, just like telehealth. We have a place of service and a modifier. So I want to be able to look at those claims and say, let's see if they were really following the rules that are there. But how would you know? It's kind of like incident too, Sean. I love that.
So Jordan, come on.
I think Terry brings up a good point, and
I could keep going, Jordan.
I like it. We bring up a good point because I was actively involved with CMS and writing direct virtual supervision, and some of the caveats, and really what CMS's intent was they did not want to spell out specialties. That's generally not CMS's intent, to spell out, hey, you can do direct virtual supervision for radiology, but you can't do it for med-onc, but you can do it for this. That's generally not CMS. What CMS really looks for, and sometimes we don't have this, and I really like what Terry brought up here, is for the professional societies and organizations to step in and say, hey, these are the rules, the guardrails, the plan of how we're going to do direct virtual supervision. This is not so you can be late and sleep in as a physician. It's not so you can be on vacation and go to the coffee shop. And we all know 100%, like Terry said, is, if you give it an inch, somebody's going to drag it a mile, baby. And that's and I think that's where we have to professionally step up and be accountable for each other and practices, because to go back to 100% and not even have it as an option would be harmful, I think. And so, some of the policing there that's involved is on us, is on the physicians within practices. I mean, we've stood up, I think, our 4th program now. We've worked with large systems and organizations. And it's funny, when you get in the weeds of, this is the documentation, this is who's going to be doing the direct virtual supervision, where they're doing it from, who they're going to be doing it for. They can only do it for this, and this. And so it gets in the weeds and that's how everybody should really approach it. This is not a blanket, it's the Wild West, and that's where people get hurt. And unfortunately, I hope we don't have to see that. So
the problem we have is that people don't want to hear best practices. They want to hear, what's my legal right to do it? And they're like, where does it say I have to do that?
And that's where I want to come to Joe real quick. And then I want to come to
Joe too.
Stephanie and Scott and David on this. So Joe, we always get to the point of, well, what's my legal exposure, right? And And again, this is the disclaimer for everybody out there. This is not a legal program where we're giving legal advice. Joe is not your attorney. You know, if you want Joe to be your attorney, by all means, go and retain Joe, and he can answer your questions and be your attorney of record. But Joe, just from a 30,000 foot view, if you could talk a little bit about, you know, the legal exposure to violating these guidelines.
Well, I mean, one is your license is on the line. So you potentially could run a risk of malpractice, but also a licensure issue. And I think, you know, Terry's case, while interesting, probably is not that unusual. And there's probably some varying degree of that. But, you know, if you're going to push the envelope, you really are running into a danger zone of a malpractice issue. And also, I really do believe that you could have a licensure issue as well. So that's kind of my thoughts on that. So.
And I agree with you. I agree with you 100%. So listen, don't listen to me when I say telehealth. It's virtual health. And again, listen to the experts that are talking about this.
Terry's going to get you again, direct virtual supervision.
Okay, fine. Direct virtual. Listen, the audience knows the audience knows my shortcomings after now 9 seasons. Okay. I want to move into one of our last conversations, and I just as I felt like clinical laboratory is a redheaded stepchild, right? And we don't get a whole lot of play in that area. We don't read a whole lot about it. I mean, yeah, you know, we see these big indictments for these massive healthcare fraud schemes where genetic testing, you know, was being ordered by these bad players around the country. But really, what I wanted to do was to identify the highest risk areas for clinical laboratories in 2026. And I was absolutely, in a great way, shocked by the amount of feedback that I got on the high risk list that I put out, and the number of reshares and reposts and comments and things of that nature, which led Stephanie to say, hey, there's something going on here with PAMA and these clinical laboratories. So Stephanie, can you, for our listeners, provide some insight on what PAMA is, and then talk a little bit about what's going on in that clinical lab space, please?
Yeah. So, and I'll explain this at the level that I understand it. I think Jordan from the data analytics could probably even dive deeper into this. But it's essentially looking at the cuts to the laboratory services. And one of the things that I thought is very interesting, and you know, I've been reading so much about it, trying to understand like the different national associations' thoughts on it. From my perspective with my clients, I'm just looking at the fact that, okay, we're going to have a pay cut, and or they're trying to cut the pay. We've already had some of the types of services cut. I'm also starting to see things around, for example, like simple screenings we're used to with diabetes, for example. I think it was United Healthcare I was looking at last week, but they're going to be limiting the number of A1C testing, or limiting the number of PSA tests, things like that. So, you know, for me, from what I do and to seeing the benefit of these tests with my clients, it's just very concerning, because I'm thinking not only of the laboratory, which a lot of them are painted in a very negative light, which that's not what I see. I do a lot of defense work in this area, but you know, I'm not working with these people who are out there greedily, you know, trying to bill all these services and get all this money in. I know that exists out there. We've talked before about, you know, telehealth schemes and things like that with genetic testing. That's not what we're talking about here. And my concern with the cuts is really what that's going to do to affect the patients. Because a lot of the defense work that I do, you were talking about molecular testing, Sean. And, you know, for years now, we've had all of these labs doing a lot of really urine testing is a high utilization area. And we're seeing a lot of benefits from the patient's perspective where it's stopping, multiple hospitalizations. In the older population, a UTI is going to be a pretty severe risk when compared to someone else. They're able to find the specific organism and then also test and find the antibiotic that's going to work to treat them. So I have a lot of concerns from that. And, Jordan, I'd like to get your thoughts on the data and the comparison, because some of what I've been reading is talking about the fact that when CMS tries to pull in all of this data and they're looking at reimbursement, we have the large players in the game like Quest, LabCorp, and they, of course, are going to have high volume. They have a lot of contracts. So, I view that as players like that, corporations like that, are going to essentially skew some of the data, which I don't know if that's the right way to look at it, but it's throwing it off to some perspective where we're still going to have physician laboratories, independent laboratories that are going to be affected.
Oh, it's a huge frustration, and I get some of this. My wife actually works in the lab, and so we get to hear a lot about this on my own time. And I think you bring up a good point: is the lack of correctness for weighting these cuts, and the weight falls on the majority, like you said, are these huge companies. So for them, what may seem a small cut, no big deal, to an independent is basically they're going to be shutting their doors. And so then I think you get into, Joe, you could talk about this. Then we get into a monopoly situation, which turns into something totally different. But to your point, I think the data that they're looking at, as they've resumed these cuts, to look back, whether it's, an outpatient lab, whether it's for the DRG or whatever it is, I think they've got to look at a way how, for some form of asymmetry, when we look at site neutrality, we do this with the data too, is how they appropriately weight it. And also the geography matters. And I think that's something that we haven't seen as much, as where are these labs actually located? And so, the current salary wage index and GPCIs don't necessarily fully account for all of that. It does its best. But I think that has to be really looked in. Is we all know that staffing models look different. The cost to provide the service is different based on location. These are all variables that have data behind them that really have to be looked at.
Yeah, David, I saw you kind of nodding in agreement there as Jordan was talking about this. From your experience working within the federal payer program, can you add a little more context to this? Sort of, what was the mindset behind this, or what were the marching orders that were provided to you all when you were with the UPIC or you were working with the different government agencies?
So I think this goes almost like when we started with prior auth. Everything starts with good intentions, and somebody thinks they have a right idea that this is going to help. They've heard reduce the drug prices, reduce this, because they're trying to make it so you can reduce the cost. But to your point, Stephanie, about the actual, I don't want to say common sense, but the ability to actually analyze the data appropriately. And I'll take this from the UPIC perspective, which is when I had multiple states, multiple regions. So Jordan, your point about geographical areas, I could not compare New Mexico to just even Houston alone. New Mexico would never exist if I'm looking to try to identify fraud. Same concept when you're looking at where these services are being provided. Don't compare Houston to a New Mexico lab. They're never going to match. You're never going to be able to say proportionately that makes sense to line those things up. So I think you take that and then wrap it. One more point, you asked a little bit about the Part C and the monster of what that is and the cost. Even when you're looking at these things, I see they're asking for provider contracts and rates. Those are all going to vary too. They do even within the health plans, which also create problems because provider A gets paid more than provider B. Provider B finds out, they're going to be mad at the health plan. So you create all this consternation between the groups, and you try to keep it all secret and keep it, let's just keep it tamped down. I'll pay you here and I'll pay you there. That's the biggest fear that everybody's worried about, is who's getting paid in what, from that perspective. So you combine all those, and then somebody just says, well, let's just cut costs 15% across the board. In the end, it just doesn't make sense because you're trying to quiet so many voices, but with a good intention. The intention is really there to help. The problem is you create something, and we get accused of this with fraud. Never paint it with a broad brush. The same should be done when you're looking at policy and things like that. You gotta be able to dissect it and do it proportionately to where the areas are and what the issues are.
Such great insight on that. All right, so we have now gone through prior authorizations. We've gone through direct virtual supervision. Did I get that one right yet? Okay, I got that one right. And now we've gone through the discussion of what's going on in the clinical laboratory. So I have 5 minutes left. And I want to bring up a topic that Terry's probably going to disconnect on, but that's okay. I do. I want to talk about incident 2 billing provisions, but we're not going to get into a whole long discussion because we really have just a short period of time. And I want to talk about it because I did a call this morning for about a half an hour with a group of incredibly intelligent ladies with a subspecialty organization. And the question of incident 2 popped up. And here's the simple question. Okay. Should incident 2 exist?
Not with direct virtual supervision. So, but to Terry's point, so we just had to, with 2 large networks, get into incident 2 and how it cross corresponds with direct virtual supervision.
Yep.
Because there is some significant overlap there, and that has to be looked at. So Terry, I mean, what do you think on that?
I don't like incident 2 because again, there's no identifying claim factors. There's no modifier. You're trusting that the doctor was in clinic, and like you said, now they're saying that the incident 2 can use the virtual supervision, which to me, virtual supervision has to do with testing, has to do with what you can do procedures, and they're using it as an incident 2 situation, and I just think the crossover is a blurred line. And I got doctors now that are saying, well, we're going to now model our practice after this virtual supervision on incident 2, and I just think it's a bad idea.
Well, Scott, let me come to you because you and I have done a tremendous amount of work with hospital networks, health systems, physician group practices with respect to incident 2. And every time we have a client that reaches out to us and says, we need our documentation looked at, what would you, and then David, I'm coming to you, and then Joe, I'm going to give you the last word on this. Scott, what would you say the error rate was? And Stephanie, you too. What would you say the error rate is for the charts that you all review on a regular basis when it comes to incident 2 billing provisions?
100%. Scott, you go ahead from there.
Well, Scott, you don't have any audio, so I'm not sure what's going on your end.
Well, I'll just say quickly,
Go ahead,
100% error rate, because nobody wants to look at the fact that there is a change in clinical workflow to do that compliantly. They just want the reimbursement, which is why I don't think we should have it. And, to the point with the virtual component coming in, that is why I have issues with the virtual supervision. Because we, even during the pandemic, Sean, you and I would go to a client and they want to, employ people based on this or employ less people, I should say.
Yep.
So I don't see the benefit to the patients, and it's all a money game. And as much as I work with physicians to try to be compliant, they don't do it right.
Yep. David, let me come to you. Scott, I don't know if your audio has cleaned up or not. I don't think so, but David,
Can you hear me?
Yeah, go ahead.
Okay, yeah, no, the point I wanted to make is that for me, the incident 2 error rate, I wouldn't say is 100%. I think it's like 75 or 80%, but it tends to be certain visit types that are less likely to have an error rate. So a patient who, has recovered from a fracture outside of a global period, who is just being told to, go back to work or whatever. Service types tend to do a little better, but I just think it's kind of a stupid policy to say, well, if you do it by yourself, we'll just pay you less. But if you do it with somebody else in the office and able to directly supervise or virtually, we'll pay you more. And it just doesn't make a lot of it. From a policy perspective, it just seems like a financial impediment, mostly because you're saying, well, you can do it one way or another. It's just money.
David, simple question for you. How much did you guys salivate when you were at the UPIC when you saw Incident 2 services popping up on your radar?
I mean, I guess it goes down to the whole thing of the error rates as it becomes to, it really is a compliance issue. Can people do this? And I mean, I've had, I go all the way back when, the doctor had to be in the clinic, they had to be there. And, there was even a distance of if they were across the hall, that was too far. And then they expanded it to, okay, they can be within the building to, oh, they can be with on the phone. So it's been one that over the years and COVID just even added to that. It's just become more problematic because the distance that the provider can be has just gotten greater over the years. So it was very easy when you had the case that said, oh, the doctor has to be in there. And I confirmed he was out on the golf course. That was a win. Then it got to be, well, he was next door. He was in, and they had a lab. So they were in the lab next door. Did that qualify? It just becomes problematic.
That's right. Joe, last question to you. Of the cases that you've had to address, both from an administrative perspective as well as from a litigation standpoint, how many of those cases had an element or had a specific finding of violation of Incident 2?
Hard to quantify. Of those inherently done wrong. And it's not a new rule. So I've always struggled with why can't they seem to understand this? Perhaps the fate of Incident 2 will be that of consults.
Yes.
At some point. So.
I agree with you. All right. That's going to wrap it up for this first brand new revised Monday Roundtable on the Compliance Guy. I cannot tell you how excited I am to have both our returning all-star cast of characters and our new cast of all-star characters joining us. I want to say thank you to David Duhaime, Jordan Johnson, Terry Fletcher, Stephanie Allard, Scott Kraft, and my buddy Joe Rivet from Rivet Law. We will get this thing up, edited, and onto Spotify, Apple, and more than 80 different podcast platforms. You'll be able to watch it both in the video format, or you can listen to just audio. Should be up in the next 24 hours. We'll be back in 2 weeks. Yes, I know it's going to be President's Day, but I'm pretty sure I'm going to have enough to have a roundtable that day. And if not, I'll do it by myself. But we will be back on President's Day. Terry Fletcher and I are coming up tomorrow with a brand new hashtag Terry Tuesday. I'll have another great episode with another amazing guest later this week on the Compliance Guy. So until then, remember, be good to yourself, but more importantly, y'all be good to each other.